Hello from Melbourne in Australia. I'm Kate Leslie, and it's my great pleasure to be with you this morning. I'm pre-recording this podcast, but I will be online and participating in the chat, and also available to answer questions at the end of my talk. So I look forward to chatting with you then. So what I will do now is I'll share my slides, and I'll put them on the full screen, and you can see me up there in the little box, and we'll get started. So I've been asked to talk about depth of anaesthesia and long-term outcomes after anaesthesia. The opinions in this talk are my own, and they don't necessarily reflect those of my organisations, and I have no potential or actual conflicts of interest to declare in relation to this presentation. This time last year we were in Orlando. My friend Tim Short made the first presentation of the results of the balanced anaesthesia study, and we celebrated afterwards with our co-investigators, and we had a total ball. Then 2020 happened. What a disaster. And it's changed everything. It's dramatically changed the way we're living in Australia. We're in lockdown in my city of Melbourne. I can't go more than 5 k's from my house. I have to wear a mask outside. And I've got to wear PPE at all times at work. And there's no visiting. It's been very difficult. And my life has become one big Zoom meeting, including giving a lot of talks in the middle of the night to people in North America. But it's a great relief to be talking about interesting research and fascinating new developments rather than COVID numbers and bushfires and American politics. So thank you very much for having me. My talk has 4 parts: a short part at the beginning about perioperative outcomes for the elderly, then a discussion of observational studies on depth and outcome, a discussion of the small randomised trials that were done, and then the balanced anaesthesia study at the end. More than 300 million patients have surgery annually worldwide, and an increasing proportion of those patients are elderly and at risk of postoperative morbidity and mortality. There are few proven primary or secondary prevention measures for major perioperative events, and the resources for monitoring and treating complications are inadequate, so more action is required. My colleague David Story led a project that we did 10 years ago now, a prospective cohort study called the Reason Study. We looked at more than 4,000 elderly patients, many of whom had pre-existing comorbidities. And at 30 days, we documented a 5% mortality rate. That was 1 in 20, which was a great surprise to us, actually. 9% of the patients had an unscheduled intensive care unit admission, and 20% had suffered a major complication. So we began to look for things that would prevent major perioperative events, mainly in the elderly and people having major surgery. And we have failed to come up with the silver bullet. Beta blockers caused myocardial infarction, but increased the risk of death. Clonidine had no benefit, but caused hypotension, and aspirin caused bleeding. Restricted fluids had no benefit, but were associated with an increased risk of acute kidney injury. We looked at the emission of nitrous oxide twice and found no benefit, and no particular increase in the risk either. There's insufficient evidence with respect to statins and epidurals, and they're very difficult to study. And finally, there's the depth of anaesthesia, which is what we're looking at in this talk today. We know that anaesthetic requirement varies with a number of factors, the most important of which are probably age and the presence of adjuvant drugs. So age has a profound effect on MAC, with a significant decrease in MAC from childhood through to old age. And what this means is that elderly patients are at risk of absolute anaesthetic overdose. This is a study in 2 hospitals that looked at the delivered concentration of volatile anaesthetic, which is on the y-axis, and age on the x-axis. And on the left is the unadjusted MAC values, and on the right is the adjusted MAC values. And the dotted line is where you would be if you received an appropriate amount of anaesthetic for your age. And what this shows is that anaesthetic delivery decreased with age, but not enough to account for decreased anaesthetic requirement. And so this meant that an absolute anaesthetic overdose was common in elderly patients. There's also a problem for the elderly with relative anaesthetic overdose. So sometimes a delivered concentration that would be appropriate for most similar patients results in deeper anaesthesia than expected. And this is called anaesthetic sensitivity. And what it means is that there are some people in the community that need a lot less than their peers, and that they're receiving a relative anaesthetic overdose. And this anaesthetic sensitivity could be due to other factors like frailty. That's yet to be determined. But what it means is that the elderly are at particular risk, not only of having more surgery, but having more complications and being at risk of absolute and relative anaesthetic overdose. So it may be that avoidance of deep anaesthesia is a potential means to improve outcomes in elderly patients. So now I'd like to take you on a journey which starts with the first observational study about the relationship between the depth of anaesthesia and outcomes, through all of the triple low studies and the small randomised trials to the balanced anaesthesia study. The first study came from Terry Monk and her colleagues at the University of Florida, where they looked at 1,000 patients undergoing non-cardiac surgery. It was actually a cognitive decline study, and this was a secondary analysis. What they showed was that patients with multiple comorbidities and intraoperative hypotension were at increased risk of 1-year mortality. But they also showed that a new measure, the cumulative deep hypnotic time, which was the total amount of time that BIS was less than 45, was significantly associated with a poor outcome. So this caused a bit of a sensation in the depth of anaesthesia world. And it was the subject of an editorial from Neil Cohen. And he raised significant concerns about this work, including the arbitrary definition of deep hypnotic time, the fact that the deep hypnotic time relied on the use of BIS, and therefore he objected to the implication that BIS is critical to avoid deep hypnosis, and also to the relative unimportance of deep hypnotic time in the model compared to comorbidity. Now, we would disagree with his criticism of the implication that depth of anaesthesia monitoring is critical. We believe that using a processed EEG monitoring is the only way to determine if a patient has anaesthetic sensitivity. That is, that if they're more deeply anaesthetised than expected based on a comparison with their peers. So nevertheless, it was an influential editorial, and Monk's article spawned a whole bunch of observational studies. And the first of these came from Watson, at Vanderbilt University who looked at intensive care patients. And what she did was looked not at burst at the BIS, but at burst suppression in sedated, critically ill patients. They looked at 6-month mortality, which was very high. And although they didn't show a relationship with intensive care unit and total hospital mortality, they did show a 2-fold increase in the risk of mortality in patients with burst suppression. Now, the problem with burst suppression is that it's not a physiologic rhythm, and it can arise from a brain insult as well as from excessively deep sedation. So this study didn't really sort out which of those two things were important. The next suite of studies came from Lindholm and her colleagues in Sweden. And firstly, they looked at 4,000 patients undergoing non-cardiac surgery, and they looked at 2-year mortality. And what they showed was that age, ASA status were very significant risks of a poor outcome. And they also showed in a model that didn't adjust for malignancy that deep hypnotic time was a significant predictor. However, when malignancy was introduced into the model, BIS monitoring and cumulative deep hypnotic time was no longer significant. And they did 2 further studies looking at malignancy and depth of anaesthesia. In the first study, they looked at patients without malignant diagnoses at the index surgery, and they found that 4.3% of them developed a new malignancy within the next 5 years, but there was no association with depth of anaesthesia. And in the second study, they looked at patients with malignant diagnoses at index surgery. 6.3% of them had a new progression of their diagnosis at 5 years, and once again there was no relationship. So the relationship between depth of anaesthesia and malignancy is uncertain. We had a look at the data from our Be Aware trial. That was in 2,500 patients, 50% of whom were BIS monitored. Our patients were older and sicker than the patients in the Monk and Lindholm study, and more likely to be male based on the inclusion criteria. They had much higher 30-day and 1-year mortality. So in our study, we had a group that was not BIS monitored and a group that was BIS monitored. And in the BIS monitoring group, we had patients who where there was no protocol violation. That is, the BIS was not less than 45 for more than 5 minutes, and we called that the optimal BIS group. And then we had a low BIS group where the BIS did go less than 45 for more than 5 minutes. And there were 3 possible reasons for this. One was that the anaesthetist was intentionally targeting a lower BIS. The second option was that the BIS was allowed to remain low when it went low. And thirdly, it could have been that the BIS remained low despite efforts to make it higher. So here we have the long-term mortality. It was 4 or 5 years later. And you can see that age, ASA status and hypotension were significant predictors of a poor outcome. You can see that the low BIS and the no BIS groups were no different. That's probably because they both had low BIS. You can see if the BIS was kept in a good range compared to the no BIS group, then the result was better, implying that the BIS was low in the no BIS group, but we know that it was based on the volatile anaesthetic delivery. And finally, you can see that the low BIS group was worse compared to the optimal BIS group. The results persisted for myocardial infarction and stroke. This is one of the only studies that has shown that depth of anaesthesia or found an association between MI and stroke as well as death. So there's the stroke data. So Dr. Kurata wrote an editorial about our paper, and he made some of the similar criticisms, and notably he highlighted the fact that there was lack of detailed hemodynamic data collection, pointing out that there may be confounding by low blood pressure in the deep anaesthesia group. So the crew at Washington University used the Be Unaware trial to do a couple of studies. And the first of these, they looked at the cardiac surgery cohort from Be Unaware. And you can see here that cardiac patients made up about a quarter of the patients, and that, that about half of these didn't have adequate BIS data. So in fact, this study only included a very small number of patients. And what they showed was that the 3-year mortality was 22%, and that the deep cumulative hypnotic time was a significant predictor of 3-year mortality. Now, interestingly, Terry Monk made some astute observations about this. She wondered if you identify these patients with a low intraoperative BIS value, what can you actually do to improve the outcome? Does optimizing the BIS into a higher or lighter anaesthetic range improve the outcome in these high-risk patients? Or is it all futile because it's actually anaesthetic sensitivity that's the problem? They then looked at the non-cardiac surgery cohort from Be Unaware, and what they showed that there was no difference. And they didn't really have a particular explanation for that. In fact, it's hard to work out why they would show that for one and not the other. Cor Kaltman wrote an editorial about this one. It's certainly been a rich field for editorials and comments. He made some of the same observations, but particularly that their important confounding variables were probably missed. And so the association with this, with outcome, was probably overestimated in the cardiac study. Back at Washington University, they used some of the data to look at burst suppression. And so they showed that there was 90-day mortality here of 3.9% in this study. And they were looking at burst suppression, which was a cumulative burst suppression of more than 5 minutes. And they showed that while EEG burst suppression was not associated with the outcome, and nor was low mean arterial pressure, an interaction between those two was highly significantly associated with a poor outcome. So that sort of dovetails in with the triple low research that we'll talk about in a minute. So Tim Short and I wrote an editorial about this one, and we were quoting Donald Rumsfeld when we talked about the different types of unknowns. So when we do observational studies, we know all about the measured variables that are known to be associated with the exposure and the outcome. They're the known knowns. And we know that there are some unmeasured variables that are associated with the outcome that we haven't measured. But then there's the unmeasured variables that we don't know are associations with the outcome. And the only way to balance all of those unknowns and unknowns and unknown knowns is to do a randomised controlled trial. And you have to do a big randomised controlled trial. So here's the summary of the observational studies. And here's the ones that show a significant association. And here's the ones that don't show a significant association. And you can see that the early ones do and the later ones don't. So it's been very interesting to see the influence of those observational trials on the future. So what I'm now going to talk about is the observational studies to do with the concept of a triple low. And this work originated at the Cleveland Clinic, where they looked at 24,000 patients from their large database having non-cardiac surgery, all of them with this monitored, and none of the anaesthetists were blinded.
What they did was that they developed a reference range here. These are the mean, MAP, BIS and MAC, and that's the standard deviation. And they defined a low as a value that was more than one standard deviation below the mean value. Here's 30-day mortality, the relative risk of that. At the top there are the single lows. And you can see that the only single low that's associated with the worst outcome is a low MAC. That is low anaesthetic sensitivity. Then the next panel down, you can see the double lows. And the only double lows that are associated with a worse outcome are those that include a low MAC or low sensitivity. And then you can see that there's a 4-fold increase in the risk of 30-day mortality if you have a triple low. And on the right-hand panel, you can see that it seems that the duration of the triple low seems to matter. And that in this study, at least, the duration of a triple low of more than 15 minutes was associated with a worse outcome. There was an editorial about this paper as well. And what they wondered was whether triple low was detecting patients at increased risk of mortality. They wondered whether hypotension is the stress test in patients with frailty demonstrated by anaesthetic sensitivity. And the hypotension, the perioperative hypotension literature has taken off since that point. And firstly, they wondered if triple low is causal, is it the hypotension, is it the EEG birth suppression, or is it both that matters? So at Duke University, they tried to replicate the triple low study. And here's their results. So they looked at 30-day mortality. They defined these thresholds for their triple lows. And once again, they showed that age and ASA, physical status and comorbidity were associated with the worst outcome, but they were unable to show that a cumulative duration of a triple low increased the risk of a poor outcome. And here's their intermediate mortality, which was a couple of years later, and we see the same result there. Here's another study now from the same, using the same kind of technology, but from a different centre. And they were able to replicate the triple low outcome. So you can see on the risk, the relative risk of perioperative mortality. Here's the single lows, the double lows, and the triple lows on the left-hand side here. I'm not sure if you can see the cursor. And you can see at the bottom that a triple low was significantly associated with an increased risk of 30-day mortality and 90-day mortality. And in this study, there seemed to be no safe duration of a triple low. Maheshwari and colleagues looked at this in cardiac surgery, and what they showed was that there seemed to be a sort of slight association with a prolonged concurrent triple low. And also Cheng et al. In China looked at cardiac valve surgery with a particularly at-risk group of patients. And they possibly showed a slight relationship between cumulative triple low and the outcome. So these are the triple low studies, and really apart from the first study by Sisler and colleagues, the other studies have really failed to show a strong association between triple low and the outcome. But the good thing about the triple low studies was that it launched a more global view about the factors that might be associated with a poor outcome in these patients. And here's a meta-analysis of some of the observational studies and triple low studies that have been done so far. So you can see the pooled estimate is that there's the odds ratio here is 1.21 with significant confidence intervals. The problem with the meta-analysis is that it's missed a couple of studies. It's used burst suppression
in some of the studies, and some of the data can't be actually found in the papers. So in summary about the observational studies, there's been a lot of studies, a lot of commentary. It's been great for catchy titles to your paper, and Tim Short and I have made a contribution to that, for which we apologise. So in the end, really, only adequately powered randomised trials can answer this question. So because observational studies are at risk of bias and overestimation of the effect, the associations with poor outcomes have been inconsistent in the observational studies. They've been unable to untangle the effect of anaesthetic sensitivity, and also confounding by hypotension. So they're unable to determine causality. So now I'll move to the randomised trials of depth and outcome. And the first of these came from Matthew Chan, who was looking actually at delirium. And he randomised patients to routine care or BIS monitoring. You can see there was a significant difference between BIS values and MAC values and propofol values between the two groups. But he managed to avoid a significant difference in hypotension, and there was no difference in 90-day mortality. In fact, it was higher in the BIS group. This group from Germany also did a study on delirium, where they randomised people to routine care and BIS values. And unfortunately for them, they were unable to get a significant difference in BIS values between the two groups. Although there was a significant difference in the amount of burst suppression. And interestingly, there was also a significant difference here in the number of people who got volatiles and propofol. And the 3-month mortality was no different in this study. This was a study called Delight that came from the Cleveland Clinic, and it was stopped early because of futility. And you can see that futility graph over here on the left. In the centre panel, you can see the odds ratios and confidence intervals for the effects of glucose control, anaesthetic depth, and dexamethasone on the primary outcome, which was any major morbidity. And then on the right, you can see why this didn't work. So they got inadequate separation between the two groups in the study, although there was quite a big difference between the amount of burst suppression. Tim Short led a pilot study for the balanced anaesthesia study in New Zealand, where he randomised 125 patients having major non-cardiac surgery with volatile-based general anaesthesia. We achieved really good separation in this study between BIS values and MAC. We managed to keep the mean arterial pressure relatively stable and relatively high. You can see that in this pilot study, unfortunately for the patients, but good for us, we found a group of patients with many major complications and death. There were a couple of studies that were done looking at delirium in hip fracture patients that had secondary studies looking at mortality, and they came from the Johns Hopkins group. This was the first one. They took these elderly patients and gave them either light or deep sedation. And you can see that if this was all of the patients in the top two panels here, and there was no difference. But in the patients who had a Charlson score of more than 4, you can see the light patients did much better than the deep patients. So deep sedation seemed to be worse for people who already had a lot of comorbidity. We wrote an editorial about this one, and we cautioned about the implementing the results of this study due to the small sample size, because there was imbalance in the baseline characteristics in this study, and there may have been exaggerated estimates of effect size for the true effect. That's the winner's curse and large and wide confidence intervals. So this group did another study on delirium and another long-term follow-up study. And you can see that the bottom panel over there shows that there was no significant difference at all between the light and the deep group in terms of cumulative mortality over a 1-year period. And then Sessler did a study looking at randomized alerts for triple low. So if you randomize people to an alert, presumably the people who in the alert group will have less deep anesthesia. So in effect, they're being randomized to light and deep anesthesia. And they looked at 90-day outcomes. And what they showed was that alerts didn't work. So, and one of the reasons for that was that helpful responses occurred in 51% of patients in the alert group and 47% of patients in the no alert group. So people were responding to the material before the alert arrived in order to try and avoid getting the alert, which they didn't really like getting. And this type of idea was replicated in New York, where they showed that over time the control group actually was doing the same as the alert group because they were trying to avoid getting an alert. And they showed in this study that a double low that lasted more than 30 minutes was associated with a worse outcome. So alerts actually, unfortunately, don't work. It's a fascinating field of study about human behaviour in anaesthetists. And I think finally, this is the Engager study from Washington University, where they randomised people to an EEG-guided bundle of care that was aimed at reducing the risk of delirium. And specifically, they were asked to avoid burst suppression. But there was also a bunch of other things that they were supposed to do. And the usual care group was usual care. And you can see that, that the vasopressor use and the duration of this less than 40 and burst suppression were different between the two groups. And there was also a difference in mortality. The mortality was higher in the usual care group than the EEG-guided care group. But they didn't comment much on this as it was a secondary endpoint. And the problem with the Engagers trial with respect to depth of anaesthesia was that they didn't manage to avoid burst suppression in the EEG-guided group where it was supposed to have been avoided. It's pretty hard to avoid. So it's not surprising. This is not a criticism of the anaesthetist, but it means that it's not clear if there was a significant pathophysiologic difference between the two groups. So here's a summary of the randomised trials, and in fact, none of them have shown that there's any difference really that's significant. So all of these trials have been too small. There've been separation of the groups has been too low. They've lacked generalisability with respect to, say, the hip fracture studies, and that they had a primary purpose, most of them, other than to determine the relationship between anaesthetic depth and poor outcomes. So now it's time to tell you about the balanced anaesthesia study. So the pathophysiologic rationale is that deep anaesthesia is associated with hypotension, immunosuppression, brain toxicity, and death and disability. The observational studies have mainly been looking at the idea that if you give people too much anaesthetic, they get a low BIS and they die. But it's really more complicated than that. If you don't use a processed EEG monitor, you can't really tell the difference between patients who have high sensitivity and patients who have normal sensitivity. And so you can give people a relative anaesthetic overdose as well as an absolute anaesthetic overdose. And this causes organ toxicity and immunosuppression and hypotension. And they are the real causes of the problem and not actually the suppression of the EEG. And the only way you can sort this out is by keeping blood pressure steady, and by monitoring the EEG to avoid over anaesthetising people, and then to see if there's a difference in the outcome. So we did the balanced anaesthesia study over the last 10 years it took. And this was a study that was conducted under the auspices of the ANZCA Clinical Trials Network. Our trials network has been going for about 25 years. We have been awarded more than $35 million in funds, and we've done more than a dozen large randomised controlled trials, either off our own bat or in collaboration with international colleagues. Just to plug, our latest study, PADDY, has been submitted to a journal. This is dexamethasone versus placebo. Thomas Corcoran will be making a worldwide webcast about that, and hopefully you can attend just before it's published. I'd like to acknowledge the other chief investigators in the balanced anaesthesia study. Tim Short led the trial. He's an anaesthetist from Auckland. Doug Campbell was managed all of the data, or a mountain of this data. Davina McAllister was the trial manager, and Chris Frampton was the trial statistician. And I always say you can tell that because he's not smiling. We had a fantastic support from our committees and project office at Auckland and the Clinical Trials Network office in Melbourne. And we conducted the study in 74 centres in 8 countries worldwide. And you can see them listed there, and hopefully some of our fabulous contributors are in the audience today. Tim disclosed a few consultancies, but none of the other investigators had any conflicts of interest. And it was solely funded by peer-reviewed national funding. There was no input from manufacturers of the BIS monitor. And the hypothesis was that light anaesthesia reduces all-cause mortality 1 year after major surgery under volatile-based general anaesthesia, compared with deep anaesthesia or a BIS of 35. We included older, sicker patients having longer surgeries where we were able to monitor the BIS. And we excluded patients having propofol maintenance, nitrous oxide, too much ketamine, cranial or intracranial surgery, and wake-up test patients. Now, key parts of our procedure were that we asked the anaesthetist to choose a mean arterial target range that they were going to defend during the case before they found out about the randomisation. We asked them to keep the BIS within 5 BIS units of the randomised target and to maintain the MAP. And apart from using volatile anaesthetic maintenance, the rest of the care was at their discretion. And we followed patients up at multiple points over the following year. So as I said, the main primary outcome was all-cause 1-year mortality, and we looked at a range of cardiovascular, infective, health service, and prolonged patient-centred outcomes. All of these were defined in a procedures manual. They were assessed by blinded observers. They were adjudicated by a blinded endpoint adjudication committee, and they were monitored by our data and safety monitoring committee. We thought that based on our previous studies that the 1-year mortality in the deep group might be about 10%, and that the 1-year mortality in the light group might be about 8%. So that meant we needed about 6,500 patients. And we had a pre-specified intention to treat population for the primary analysis and a pre-specified per protocol population for a secondary analysis. So the results were published in The Lancet this time last year. Here's the flow chart. We didn't lose too many patients between enrolment and analysis for the primary outcome. Here's some of the baseline data. The patients were elderly, 2/3 of them were male and 1/3 were female. They're a little bit overweight on average, and most of them were ASA physical status 3, despite efforts for us to recruit patients who were ASA physical status 4. And they had a reasonable amount of comorbidity and disability. Half of them also were having abdominal surgery, with a smattering of other specialties with high-risk surgery. About half of them were having an operation for cancer. And here is the data about intraoperative management. So you can see that there was about an 8-point difference between BIS values in the light and the deep group. So although we didn't achieve 50 and 35, there was still a substantial difference between the MAC that was delivered in the light and the deep groups. About half of the anaesthetists had difficulty targeting the BIS value, but you can see that they were very successful in targeting a MAP, and you can see that the mean arterial pressure that was defended was nice and high. It seemed unlikely, based on all of the subsequent hypotension research, that hypotension is a confounding factor in this study. But that came at the cost of a very high use of inotropes, in particular metaraminol, which is what we use in Australia. This is a pictorial description of those data. You can see a difference in the BIS values, not very much difference in MAP values, and a big difference in MAC values. And these are some of the post-operative data. The deep group patients stayed in the PACU for a little bit longer. That wasn't significant. And there was no difference in quality of recovery, hospital stay, or disability. So this is the primary outcome, and you can see that there was no difference in 1-year mortality between the two groups. 1-year mortality was 6% in the light group and 7% in the BIS group. The hazard ratio was 0.88 with the confidence intervals of 0.73 to 1.07. Here are the secondary outcomes, and there was no difference in any of the secondary outcomes between the two groups, either cardiovascular, septic, or health service related outcomes. There was one incident of awareness. This was in the light group, and it was due to technical and judgment issues of the anaesthetist, and not really just purely due to, we don't think, the randomisation. And there was no difference in the recurrence of cancer. There was no difference in most of the persistent pain variables, except for the incidence of the severity of neuropathic pain at 1 year. This is a small minor dot point in our secondary analyses, and the hypothesis generating at best. This is the per protocol analysis. So only about 2/3 of the patients actually achieved a situation where their median BIS value was between 45 and 55 or 30 and 40. But the results are nearly identical to the intention to treat analysis, even though the sample size was a lot smaller. And here's our updated meta-analysis, which, with the pooled result that there is no significant difference in the risk of mortality between patients receiving light anaesthesia and those receiving deep anaesthesia. So the balanced anaesthesia study was the largest randomised controlled trial to date. There was adequate separation of BIS and MAC between the groups. There was comparable mean arterial pressure between the groups. Only 5% of the patients had an ASA physical status of 4, which was a disadvantage. We had difficulty tracking the BIS in some of the patients, and the incidence of the primary outcome was lower than expected. So this has drawn criticism in the commentary that this study was underpowered. But we think that it provides the best evidence to date, and is very reassuring that if there is a difference, it's probably small. And we don't know if anyone is going to have the energy to repeat this study in any case. It was certainly an odyssey for me and Tim and the gang in the anesthesia, the ANZCA CTN, to complete this study. So our conclusions are that when compared with deep anesthesia, light anesthesia does not improve 1 year survival and does not increase the incidence of awareness during anesthesia. We think that the balanced anesthesia study provides a broad range of depth over which anesthesia may be safely delivered in older comorbid patients. And we think it supports the safety of anaesthetic titration using processed EEG monitors. If you want to identify patients with anaesthetic sensitivity, you need a monitor of the brain, and these processed EEG monitors are the only ones that are currently available. So that's what I've talked about today, and I hope that you enjoyed my talk, that you have a wonderful virtual conference. I hope it's a great success, but not successful enough that we don't meet in person in the future. So this is what I advise. Consider using age-adjusted MAC values and TCI algorithms because they'll help you avoid overdose. Consider using an EEG monitor because that's going to help you avoid anaesthetic overdose and hypotension, and probably avoid anaesthetic-induced burst suppression. I haven't talked about delirium, and that's because my friend Liz Everett is coming up next to discuss research on preventing postoperative cognitive decline and delirium. And one of the things she's going to tell you about is the sub-study of the balanced anesthesia study where we looked at that very topic. So stay tuned for Liz's talk. Thank you very much for your attention. Stop recording now. Speak to you soon.